Genital herpes and genital warts are recognized as the main sexual transmitted viral infections that might be acquired by any types of sexual contact. Risk groups: 1. Adults who have multiple sexual partners. 2. Immune-compromised individuals. 4. Infants who have infected mothers. 3. Sexual child abuse. Genital herpes. Etiology: there are 2 species of herpes virus capable of causing genital herpes: herpes simplex virus type 2, HSV2, and herpes simplex virus type 1, HSV1. 90% of genital herpes cases are due to HSV2 infection, whereas 10% are due to HSV1. Both HSV1 and HSV2 are structurally very similar and share about 70% sequence homology. Disease syndrome of HSV1, HSV2. Characteristics of herpes virus. Family of herpes viridae. Variant consist of glycoprotein envelope, icosahedral capsid, liner dsDNA. The herpes viruses has the ability to induce latent infection. HSV 1 and 2, nerve cells. HSV1 trigeminal ganglia. HSV2 sacral ganglia. Transmission of genital HSV infection. 1. Sexual transmission. The number of different sexual partners correlates directly with acquisition of HSV2 in both male and female. Homosexual men are more susceptible to HSV2 infection. Genital infection can be acquired by auto-inoculation from lesions elsewhere on the body by touching vesicular fluids from aherpetic lesions, HSV1 and 2. HSV1 can cause genital herpes infection after oral sex, also can be seen in cases of child abuse. Transmission of genital HSV infection. 2. Perinatal transmission, during delivery. The majority of maternal infection, 85%, occurs during delivery, due to direct contact between the baby and infected maternal birth canal. The risk of perinatal transmission is usually occurred in about 50% of mothers have primary genital herpes, while the risk is 8% if mother have recurrent infection. This infection can lead to either massive herpetic skin lesions or generalized infection affecting skin and internal organs e.g., lungs, liver or brain. To avoid perinatal infection we do cesarean section. Transmission of genital HSV infections. 3. Intrauterine vertical transmission, 10%. Maternal primary genital HSV infection of the mother during first trimester can lead to spontaneous abortion. Maternal primary genital HSV infection which develops after 20 weeks of gestations may induce malformation as microcephaly, jaundice, hepatosplenomegaly, chorioretinitis and herpetic vesicles on the skin. Pathogenesis of HSV2 genital herpes infection. Primary infection occurs when HSV2 infects epithelial cells covering the mucosa. The virus then migrates to the nearest ganglion, sacral ganglia, via neurons where it replicates and establishes latency for life. Once it's reactivated, it travels back through neurons to the site of the primary infection and causes recurrent infection. Once the virus enters the human body it remains for life. Latency. Clinical features of HSV2 infection. Primary genital infection. Incubation period 2 to 12 days. Vary from mild symptoms to severe painful episode. Symptoms are present. They may include fever, malaise, dysuria, inguinal lymphadenopathy, vesicular herpetic lesion or ulcer localized to the cervix, vagina, vulva or perineum of the female or the shaft of the penis in the male. Herpetic proctitis can be seen in homosexuals. Aseptic meningitis have been observed in about 10% of cases as extragenital presentation. Genital herpes. HSV2 on vulva. HSV2 on penis. Genital herpes. Neonatal herpes infection is not a common condition, but the mortality is greater than 70% when it happens. It occurs during labor and delivery through the vaginal canal when a mother is having a primary active herpetic lesion and shedding the virus, also in small percent as vertical transmission during pregnancy. It may spread to other organs such as lungs, liver, brain. Neonatal herpes infection. It has 3 forms. 1. Localized skin infection. Limited to massive skin vesicular lesions. Mild infection. 2. Localized brain infection. Limited to SNES invasion causing encephalitis. Mortality is high. 3. Generalized neonatal herpes infection. Severe massive infection of the skin accompanied with internal organs infection as lungs, pneumonia, liver, hepatosplenomegaly, and brain, encephalitis, with massive skin herpetic lesions. Usually fatal. Neonatal herpes. Clinical picture of recurrent genital herpes. Occurs after reactivation by environmental or physiological factors such as stress, exposure to UV light, menstruation, pregnancy or any condition decrease the immunity. This can be as frequent as 6 or more episodes a year. The attacks are milder and shorter than primary episode. Accompanied with the appearance of herpetic vesicles on the external genitalia. Symptoms may include pain and itching. Lab diagnosis. 1. ELISA, serum sample is analyzed for detection the IMAB. 2. Immunofluorescence, if, lesion scraping or vesicle fluid sample is analyzed for detection the AG. 3. Polymerase chain reaction, PCR, CSF sample in case of neonatal herpes. Continued. 4. Tissue culture. Vesicle fluid sample is cultured in cell line, Vero or Het2 cells, and then identified by the following. Observe the viral CPE. Direct immunofluorescence, if. Management. No vaccine is available to prevent HSV2 infection, and thus the best way to control the HSV infection is by avoid sexual contact with infected individuals. Abstain from making prohibited relations. Note, condoms are not 100% protective against genital herpes infection. Treatment acyclovir, the first choice therapy. Suitable for pregnant women. Famciclovir. Valacyclovir, family of Papillomaviridae. Family of Papillomaviridae. Virion is small non-enveloped, and consist of icosahedral capsid, circular dsDNA, 55 nanometers in diameter. HPV infect epithelial tissues of skin and mucous membrane. There are more than 150 distinct HPV subtypes. HPV cannot grow in tissue culture. The HPV early proteins, E6 and E7, are transforming proteins and associated with initiating cancer by the oncogenic HPV genotype. HPV resists detergent and heat and can remain infectious in the environment for long time. Virion is small non-enveloped, and consist of icosahedral capsid, circular dsDNA, enveloped virus. HPV cannot grow in tissue culture. The envelope proteins E6 and E7 are transforming proteins and associated with initiating cancer by the oncogenic HPV genotype. HPV resists detergent and heat and can remain infectious in the environment for long time. Resists detergent and heat and can remain infectious in the environment for long time. Human papillomavirus. Human papillomavirus. Clinical features: HPV cause disease only in skin and mucous membranes, where they give rise to warty lesions. They are usually benign, but some may become malignant depending on the type of HPV, the anatomical site involved, and the potential to cause malignant lesions. Types of warts and HPV genotype. 1. Cutaneous warts. The virus is transmitted from infected skin, either by direct contact or through fomites, and enter its new host through abrasions. Swimming pools and changing rooms are fertile sources of infection. Skin warts are most liable to affect young children. Common warts HPV 2,4. Plantar warts HPV 1,2,4. Flat warts HPV 3,10. Spontaneous remission of warts occurs in up to 2/3 of the patients with normal cellular immunity within 2 years without treatment, but recurrence is common. Plantar warts HPV 1. Flat warts HPV 3,10. 1. Cutaneous warts A. Common warts HPV 2,4. B. Plantar warts HPV 1,2,4. C. Flat warts HPV 3,10. Diagnosis of cutaneous warts. Routine laboratory diagnosis is not available for cutaneous warts, and diagnosis is on basis of clinical history and appearance of the lesions on examination. HPV can be detected from lesion biopsy by one of DNA hybridization techniques, for example Southern blot, PCR, and hybridization in situ. HPV treatment 1. Cryotherapy, freezing warts by liquid nitrogen. Suitable for small external warts. 2. Electrocautery treatment. Destroying warts by an electric current. Suitable for small warts. 3. Laser therapy. Destroying warts by a focused light beam. Suitable for small and large warts. 4. Surgical excision. Removing warts by surgical tools. Suitable for all warts. Continued. 4. Topical treatment, applied directly on external warts. Used for several weeks. Examples: salicylic acid, imicamodin podophylox. Podophyllin is applied by a doctor and contraindicated in pregnancy. Trichloroacetic acid, TCA, safe in pregnancy. 5. Injection. Interferon alpha, 5-fluorouracil gel. Could be taken for several weeks, 8 to 12. Genital warts, anogenital or mucosal warts. These warts are acquired by sexual contact. They are in fact one of the most common sexually transmitted diseases, and often occur in association with other sexual diseases as gonorrhea or chlamydial infection. There is strong association between increasing numbers of sexual partners and prevalence of genital HPV infections. There are over 40 HPV types that infect the anogenital area. Clinical symptoms of genital warts appear after 3 to 4 months after infection. IP. Warts size vary from small round to large complex mass. Found in the anogenital tract, inside or outside the genital and the anal areas of both males and females. Localized pain. Discomfort. Abnormal vaginal bleeding and discharge. Anogenital HPV. Common sites for infection include the penis, scrotum, perineum, anal canal, perianal region, vagina, vulva and cervix. The major manifestations of anogenital HPV include 1. Genital warts, condyloma acuminatum. 2. Squamous intraepithelial lesions, anogenital or mucosal lesions. Condyloma acuminata, low risk, benign, HPV 6,11. Cervical carcinoma, high risk, HPV 16,18, 31,45. Penile and anal carcinoma, HPV 16,18. In men. Laryngeal warts, benign, HPV 6,11. They may be transmitted to baby during delivery. Genital warts. Genital warts, male-female. Link between HPV and cervical cancer. HPV type 6 and 11 condylomata acuminata is usually benign and unusual to become malignant, while HPV 16 and 18 squamous intraepithelial lesion are more commonly associated with lesions of great dysplasia, which involves all layers of stratified epithelium, and has high chance of progression to metastasizing carcinoma and invasive cancer. Persistent HPV infection is considered the main cause of cervical cancer. HPV DNA can be detected in most grades of premalignant lesions of the female and male genital tract. Greater than 90% of positive Pap smear is due to HPV infection. Pap smear is a screening test for detection abnormal epithelial cells of the cervix. Diagnosis: lab diagnosis. External genital warts can be easily diagnosed by medical examination. Internal genital warts can be visualized by colposcopy. Lab diagnosis. 1 polymerase chain reaction (PCR) is used to detect HPV DNA. 2 Pap smear test is used to identify abnormal epithelial cells of the cervix, cervical dysplasia. 3 In situ DNA hybridization is used for HPV genotyping. HPV treatment: 1 Cryotherapy, freezing warts by liquid nitrogen. Suitable for small external warts. 2 Electrocautery treatment. Destroying warts by an electric current. Suitable for small warts. 3 Laser therapy. Destroying warts by a focused light beam. Suitable for small and large warts. 4 Surgical excision. Removing warts by surgical tools. Suitable for all warts. Continued. Examples: imicamod, podophylox. 4 Topical treatment. Applied directly on external warts. Used for several weeks. Examples: imicamod, podophylox. Podophyllin is applied by a doctor and contraindicated in pregnancy. Trichloroacetic acid, TCA, safe in pregnancy. 5 Injection. Interferon alpha, 5-fluorouracil shell. Could be taken for several weeks, 8 to 12. HPV prevention. There are 2 vaccines available: Gardasil and Cervarix, and both are recombinant viral-like particles with no DNA. Given in 3 doses at 0, 2, 6 months. Recommended for young individuals ages 9 to 26 years old. Not given to pregnant women. Gardasil, a quadrivalent vaccine, provides protection against HPV genotypes 6, 11, 16, 18, which causes genital warts. Cervarix, a divalent vaccine, provides protection against HPV genotypes 16 and 18, which causes cervical cancer.